Hey everyone, welcome back to the channel where medicine meets clarity. I'm Dr. Rezaian, a specialist in arthritis and rheumatology. Today we're diving into a condition that often flies under the radar, Hepatitis C-related arthritis. Whether you're a healthcare provider, a medical student, or someone living with Hep C, this video is your one-stop shop for understanding this fascinating and important topic. Hepatitis C is not just a liver virus, it's a multi-system disease. One of the most common extrahepatic manifestations is arthritis. But this isn't your classic rheumatoid arthritis. HCV-related arthritis has a twist. The root cause lies in immune complex deposition, particularly cryoglobulins. These are proteins that clump together and deposit in joints. They trigger inflammation and joint pain, acting like little troublemakers. In some rare cases, hepatitis C might even directly infect the joint tissue. But the main mechanism is immune-mediated. There are two key patterns of arthritis we see in hepatitis C. First, RA-like arthritis. This is symmetric, small joint pain that mimics rheumatoid arthritis. But importantly, it typically does not lead to joint destruction. Second, intermittent oligoarthritis. This involves fewer joints, often larger joints, and is frequently associated with cryoglobulinemia. Here's your clinical clue. Many of these patients are rheumatoid factor positive but anti-CCP negative. That serologic pattern should raise suspicion for HCV. Let's talk about the diagnostic workup. Start with anti-HCV antibodies and confirm with HCV RNA PCR. Rheumatoid factor is often positive. Anticyclic citrullinated peptide or anti-CCP is usually negative. Cryoglobulins should be checked, especially in patients with vasculitis or palpable purpura. Complement C4 levels can be low in cryoglobulinemic patients. Also include ESR and CRP to assess inflammation. Liver function tests are essential, and a fibroscan can help stage liver disease. Imaging is useful too. Unlike rheumatoid arthritis, HCV-related arthritis is non-erosive. So if a patient has joint pain but normal x-rays, think hepatitis C. Now let's talk treatment. This is where it gets exciting. Direct-acting antivirals or DAAs have revolutionized care. They don't just clear the virus, they often reverse the arthritis. Common regimens include Epclusa, 400/100 milligrams once daily for 12 weeks. Mavuret, 300/120 milligrams with food, often just 8 weeks. And Harvoni, 400/90 milligrams daily for 12 weeks. These DAAs have cure rates over 95%. Many patients see their joint symptoms improve or resolve completely. But what if symptoms persist after viral clearance? Then we shift to supportive care. Non-steroidal anti-inflammatory drugs are helpful, but use caution in patients with liver disease. Low-dose prednisone, around 5 to 10 milligrams daily, can reduce inflammation short-term. Hydroxychloroquine is a safe disease-modifying drug for mild RA-like symptoms. And for severe cryoglobulonemic vasculitis, Rituximab is the treatment of choice. Here's an important clinical tip. Immunosuppressants like methotrexate or leflunomide should only be considered after the virus is cleared and liver function is stable. During treatment, monitor viral loads and liver enzymes monthly. Track symptom improvement and inflammatory markers. After therapy, check for sustained virologic response at 12 weeks. If symptoms persist, recheck autoantibodies and cryoglobulin levels. The prognosis is excellent. Once the virus is cleared, arthritis usually improves or resolves entirely. A few patients may need long-term management, but most go on to live arthritis-free. Let's quickly recap what we've covered. Hepatitis C can cause either RA-like or oligoarthritis. Rheumatoid factor is often positive, while anti-CCP is negative. Diagnosis requires both viral and autoimmune labs. Direct-acting antivirals are the gold standard treatment. NSAIDs, low-dose steroids, or hydroxychloroquine provide supportive care. And prognosis is excellent with successful antiviral therapy. If you found this video helpful, don't forget to like, subscribe, and share it with your med school crew or clinic team. Got questions or cases you've seen? Drop them in the comments. I'd love to hear your experiences. Subscribe for weekly breakdowns of complex rheumatologic conditions. simplified and clarified